Good afternoon, everyone. Today, Dr. Sudhir Pai, who is Senior Consultant in Neurosurgery at Aster Hospital, and myself, Dr. Dhananjay Bhatt, who is also Senior Consultant in Neurosurgery at Aster Hospital, will be giving a small talk about a very not so uncommon condition, which is known as trigeminal neuralgia. To start off with, sir, we will start this discussion.
Trigeminal neuralgia is a very typical kind of a different pain, which some patients who have experience will be able to narrate. That there is a severe piercing pain, as if somebody is stabbing you, and this pain comes in episodes. Episodes in the sense, especially when after food, after taking some cold drink, or if you are sitting under a cool breeze, breeze is hitting your face. There are some by which the nerve gets stimulated or whatever, and then they experience a pain. Pain is usually in three parts like this. Because there are three branches for the trigeminal nerve. Trigeminal nerve is one of the cranial nerves which is attached to the brainstem in the brain, and as it comes out, it is distributed into three parts: orbital, maxillary, and mandibular. And most of these patients have a pain mostly in the maxillary or in the mandibular region. And there is a tendency for people to consult a dentist because this problem usually happens. And invariably at that age, everybody would have some kind of a dental problem. So they try to approach a dentist, and many times because there is a involvement of the tooth with decay or root, this thing, they get removed. So many patients who come to us with trigeminal neuralgia would have already approached the dentist, and since the pain has not gone in spite of dental extraction, they land up. And this pain comes, as I told you, usually after getting some trigger by eating food or drinking cold water or exposure to cold breeze. So this kind of a pain, atypical pain which is so severe, stabbing, and gets stimulated, activated by certain acts, then you have to think of trigeminal neuralgia. Now, Dhananjay can definitely narrate the type of pain and what kind of treatment modality is available. He will be able to narrate.
Yeah, this, as sir has rightly pointed out, it's a sharp, shooting, lancinating pain, electric shock-like sensation. People will just hold their face and they are unable to talk. And this is a typical pain which is seen in middle-aged and slightly elderly people. There are so many types of pains which occur on the face. This is one of them. There are certain pains like migraine headaches, where the pain comes on the temporal area, on the vertex area, and behind the eye. Then there are so many autonomic dysfunction type of pains which can affect the eye. The typical of this trigeminal neuralgia differentiates it from all the other pains is that it's intermittent in nature. In between, the people are completely pain-free, like as if everything is fine. And then suddenly, that pain starts appearing, sharp shooting pain. While in all the other conditions, there is always a background pain. Some background pain will be there, and in between, they will have exacerbations. And there will be throbbing type of pain or a pricking type of pain. Now, how do we diagnose this? This diagnosis is basically done by clinically. Most of us, once we see a patient with this type of pain, we know it is trigeminal neuralgia.
Distribution also helps us in diagnosing because very typically the patient will say, this lower jaw, it has started here or in the middle jaw. Usually, rarely you get it into the
around the eye and the first division pain. So once these patients come like this with severe pain, what we do is we clinically examine these patients. In clinical examinations, normally these patients will have no findings. Everything will be normal. The sensory system will be normal, the motor system will be normal, the power in the limbs will be normal, vision will be normal, everything will be normal. And then we have to investigate these patients with an MRI. MRI is one of the gold standards for investigations. Basically, it rules out any other causes of trigeminal neuralgia. See, the most common cause of trigeminal neuralgia is idiopathic, where the cause is not known, or there is something known as a neurovascular conflict, which we'll discuss later. Another condition such as demyelination, like multiple sclerosis, these can also present with trigeminal neuralgia.
So one has to investigate.
These things will be investigated. Those patients generally will be younger, they may have bilateral pain, and then they may have history of visual loss, limb weakness, episodic changes. So that will give us a hint that this might not be a straightforward trigeminal neuralgia. Rarely there may be small tumors in the brain, like epidermoids, small meningiomas, small tumors, which will touch the fifth nerve, and it will cause irritation, and it will cause this type of trigeminal
These are
neuralgia.
usually the uncommon things, but I would say more based on our clinical history, the patient what she or he narrates, the type of pain, and then you would have seen some people would have avoided brushing their teeth because every time they try to do that, the pain gets aggravated. Or some people don't even like to eat; they starve rather than to get a pain because of the severity of the pain. So the treatment modalities are also, as Dhananjay said, is varied. That means there is no one definitive treatment modality available for trigeminal neuralgia. But definitely we start with some medication and then we go further step by step depending upon the response. That I think you will be able to narrate much better.
Yeah. So we'll come back now. Once we do an MRI, so what will happen in MRI is if you rule out all these tumors, some demyelination, multiple sclerosis, etc., we typically find in idiopathic trigeminal neuralgia a blood vessel which is pressing on the nerve, the fifth nerve. It presses and deforms the nerve. So with each pulsation of the blood vessel, it will tap on this nerve and cause this sharp shooting pain. So the basic pathology, what is considered to occur in this, the nerve which is, as you all know, like an electrical wires which are covered by an insulation. So whenever this insulation is damaged or whenever there is cross connection, you get short circuits, electricity just fluctuates, short circuit, etc. So similarly in a nerve also, a somewhat similar mechanism known as hepatic transmission takes place and we get this shooting pain. So once we have diagnosed, once we diagnose with MRI, not all, MRI is not multiple sequences. We do a special sequence known as Cis3D, where we take very thin cuts and very minutely examine the area where the fifth nerve is. And then we can find out that the blood vessel is compressing on it. So once it is compressing on it, and then we find that, and then we see the clinical picture, where there are no findings, then we diagnose it as trigeminal neuralgia. And then initially the treatment modality, the treatment options for these patients will be medical management. That is with tablets. So one interesting thing is the tablet which we do is carbamazepine, which is known as carbamazepine is a tablet which is given. And the center point of this is that once this tablet is taken, if pain goes, then definitely this is trigeminal neuralgia and nothing else. Because so many times we may get confused whether some other pain is mimicking trigeminal neuralgia. You give carbamazepine, pain comes down, then definitely this is trigeminal neuralgia. So initial treatment with carbamazepine, we start off with half a tablet, one tablet, then 2, 3, 4, and we go up to around 1,200 milligrams.
Depending upon the tolerance.
The problem with this medication is that some people are very allergic to this medication. They develop a lot of rashes. Stevens-Johnson syndrome some people can develop. They develop giddiness. They get full tiredness, full
Basically,
drowsiness.
The commonest thing that we see is patient feels drowsy.
Significantly drowsy.
So you can't give most of the medicine data. You prefer to give them in the night. And we also request them to take it before taking food or something, because the moment the pain gets triggered by eating or drinking cold water or some kind of soft drink or anything, the moment it gets triggered, then the pain takes longer time to retain. So we recommend them to take preferably the tablet if it is responding. Better to take it half an hour before your major meal and see whether they respond. Many times, in spite of increasing the dose, the pain may become severe, or with 2 tablets itself the patient can manage. And over a period of time, it has got, as I said, intermittently it comes and goes. Sometimes without patient can gradually stop the medicine. We recommend them to titrate your requirement based on the type of severity of the pain. If the pain is severe, we give it comes usually as a 200 milligram tablet, carbamazepine. We give it 3 times a day. Usually prefer to give it half before food, at least I try to do that. But if the patient says, I just can't take this tablet, doctor, I can't drive, I can't work, so in that case we have to cut down the medication to the later part of the day, that means only in the night. But the whole day the pain suffering is severe. In that case, if we find an MRI which shows that there is any evidence of this thing, there are different modalities.
Because as told, this carbamazepine is the gold standard for treatment. If you can get maximum tolerable dose of about 1.2 grams, then many of the patients have good relief for probably several years. Several years they have relief.
Many times they say that okay, after I come for 6 months,
8 years, 10 years also people are on this safely.
And then suddenly out of nowhere the pain has recurred, they land up in there.
And many people cannot tolerate even 200 milligrams, 400 milligrams. So such type of patients, what we do is we try to first add on so many other medications. We add on baclofen, there are so many other gabapentin, then pregabalin. All these medications we add on and try to reduce the pain. Amitriptyline. All these drugs will help to some extent, but they are not as effective as carbamazepine.
Yeah.
So these just help a little bit and try to prolong. So normally most patients have some good relief with these medications, probably for several years, as I told, 4 years, 8 years, 10 years also people may have relief. And then some people may try to slowly taper it, stop it, and they may be free. But many people, after stopping the medication, again it comes back. It comes back. So then we have to look at other options. So after medical management, which is relatively safer than all the other invasive management, if it fails, we go on to the next step. The next steps are what we do is, which are standard and which are routinely followed, are radiofrequency lesioning. Then the next one is gamma knife radiation, and the last one and the best one is microvascular decompression, which is surgery.
See, that's what I would rather say. The majority of the patients respond well to the carbamazepine therapy, and they learn to adjust their dosage according to the severity of the pain. If they fail or if they don't respond, or for some reason because of allergy or some kind of a reaction that we are not able to give carbamazepine to this patient, he or she needs to be investigated. As he said, MRI has to be done. And what we look for in MRI is, this is not a routine MRI, we do as he calls it 3D, wherein we can see at the root entry zone of the fifth nerve, there will be some vessel going nearby to the nerve entry zone. So those are the cases who are going to be benefited by surgical method of treatment. Otherwise, we try to give radiofrequency ablation. That is, you inject a small needle which has got electric potential to stimulate it, and we try to burn that nerve.
Basically, in the brain, which is the one.
So basically, try to create a lesion in the nerve so that the nerve, the area distributed by that nerve doesn't get pain. Many in the past, before MRI came, many of these patients used to be given this radiofrequency ablation or even alcohol injection into that area, or glycerol injection.
Balloon was also used.
Then they have used this balloon. It is basically to crush the nerve or create a kind of a hurdle for the nerve to transmission. But if these don't work, and carbamazepine, if the patient is not able to tolerate, or in spite of carbamazepine, the pain is such that patient is tired of suffering from that, then we think of doing another option, that is a surgical option. Before surgical option, we just need to have an MRI of the brain done, and if MRI brain shows that there is some kind of a vessel which is nearer to the root entry zone of the fifth nerve, the chances of your surgical intervention or treatment is going to be better. And when you see that, we described you now, whether there is a carbamazepine or whether it is a blockage of the nerve, burning of the nerve with radiofrequency, or doing gamma knife, all this just shows that there is no perfect treatment available for trigeminal neuralgia. But the best form of treatment among the patients who are treated, it all depends upon the correct selection of a patient. If you have selected correctly a patient who has got a blood vessel which is nearer to the nerve root entry zone, then yes, surgical treatment will have a best result, and that I think Dhananjay will be able to.
Now before that, I'll just tell a little bit about radiofrequency ablation, the complication, the problems with radiofrequency. So the problem with radiofrequency is that its success rate is not very good. Though initially you may have 80 to 90% success rate, the chances of recurrence is very high. 2 to 3 years, good amount of patients, pain recurs. And along with this, since we are burning the nerve or damaging the nerve hydrogenically, patients will have numbness in the distribution of that nerve. They may have numbness in one area, especially in the area if it is done around the eye. The eyes will become desensitized. So the cornea will have no sensation. Then chances of damage to the eye will be very high. So that is why if patient has got a pain in the V1 division, that is over the forehead and the eye region, radiofrequency ablation is not done. RF lesioning is not done. We go for other options. Another problem with this is, along with anesthesia, sometimes they have severe pain in that area known as anesthesia dolorosa, where there will be severe pain along with numbness. So this becomes more miserable. Hence, RF lesioning is probably not a very good treatment option, but in some cases that might be the better option. People who are not willing for surgery, very elderly people who are not willing for surgery, that one is one option. Before coming to surgery, I think we'll tell briefly about radiation treatment, the gamma knife radiation. So what happens in gamma knife radiation? It's available only in a few centers in India, and in gamma knife radiation is a very highly focused gamma rays are sent and which goes directly to the nerve and it causes a lesion on that nerve. Same, it damages the nerve so that its transmission capabilities are reduced, and with that patients can have relief of pain. But this modality, the success rate is quite poor. Initially only it might be around 60-70% may have good result, which will take after 1 or 2 months after giving gamma knife. And then within a few years it drops down to 40%. So hardly 60% of the patients do not have relief from this.
Basically, the gamma knife is we recommend to the people who are not fit for surgery. They have undergone some kind of a cardiac procedure recently, or the old age is because of the age-related complication. General anesthesia is risky. Then we try this method of treatment.
Yeah. That's what people who are especially very elderly people who cannot be operated, severe pain, who cannot take amlodipine. So then the only treatment option probably for them will be gamma knife radiation. So now coming to the best treatment which has stood the test of time and has got a very long success rate, even after 10 years the recurrence rate is quite less in these patients, and that is surgery, microvascular decompression of the nerve. So what we do is we open the skull. It will be at the back. The fifth nerve which we have to treat will be at the back, behind the ear. We have to go. We remove the small portion of the skull over there, go inside, and where the nerve, we identify the nerve, and then invariably if the nerve is there will be a blood vessel which is pressing on that nerve and deforming the nerve. And with each pulsation it will be stimulating that nerve. So what we do is, in this decompression, we separate the blood vessel from the nerve and make the nerve free. And interpose in between some artificial material. Generally we put Teflon. Teflon graft is what we put, and so that there is a gap created between the nerve and the blood vessel. So once that is done, the nerve is free and the pain goes. So if the surgery is successful, immediately after surgery, once you wake up the patient from anesthesia, patient should have no pain. It's been so many times that last case also when our anesthetic Vivek wanted to put the mask for him to breathe, the patient refused because it's severely paining. He cannot put the mask. After somehow with IV anesthesia we managed and anesthetized him. But after surgery, we removed the plaster from his face, we put the mask on his face, nothing happened. He did not cry of pain at all.
Very rewarding surgery.
It's a very rewarding surgery, and immediately after surgery, patient will have relief of pain. At least 95 to 98% of the patients will have relief of pain.
It is the best modality of treatment available.
And not even after 10-15 years also, a significant number of patients remain pain-free. But however, caution that we cannot guarantee that 100% all patients throughout life will be free. But most of them will.
Yeah, and secondly, we don't offer surgery as a first mode of treatment unless they have failed or for whatever reason they are not been able to take the medicine or they are not able to tolerate the medicine or radio frequency is out of question or whether that has failed because the success rate is very poor. Then we investigate with MRI, and if MRI shows, selection of case is very important. If MRI shows that there is a blood vessel nearer to the nerve root zone, then surgical intervention, and as Dhananjay mentioned, separating out the blood vessel from the nerve root zone and then putting what is synthetic material called Teflon, which is not a big thing, it's a small material, small piece, which is put there only to separate out the nerve from the blood vessel, so that the blood vessel doesn't keep on hammering the nerve to get a pain. And usually these surgeries are very rewarding. The relapse rate is very low in trigeminal neuralgia for surgical intervention, provided you have picked up a correct case.
You think surgery is also safe in some of these patients?
Surgery is also
surgery is safe. Even for elderly people,
yes,
I think it is quite safe.
It can be offered, there is no question.
Because our anesthesia drugs are quite good,
Nowadays the risk for anesthesia is
very low. Our surgical techniques improved with our
unless there is a definite indication that we had a cardiac stent put in or a cardiac bypass surgery done, he's on blood thinner, I would like to wait, then we say okay, we give the choice to the patient. But patients, those who have undergone surgery, they will tell us, sir, we could have done this much before, because the response is so good.
Yeah. So it's safe. I don't think people should get scared that surgery, after surgery, something may happen and they not undergo surgery. Is it safe or something?
In a good center with good backup system, anesthesia, imaging, I don't find there is any reason.
There is no indication to postpone surgery.
No reason.
Because of fear of surgery.
No, that
Not
is
at all.
not.
Yeah. And generally we stop all these medications after surgery immediately. Immediately we stop all these.
You don't have to.
After surgery, all carbamazepine, the baclofen, everything, whatever medication they are taking are all stopped.
Can be stopped.
And we discharge the patient within 2 days after surgery.
Yes.
1 or 2 days after surgery we discharge. And then the follow-up is after a week where we remove the sutures, and then once in 6 months, once in a year, we follow them without any medication.
This should be even again. It is nothing to do with anything about their profession. Dentists should be aware of this, because many times when the patient comes with pain,
patients have got
they inevitably would have come with some tooth already removed, the wisdom tooth or the biting major.
No, I think nowadays dentists are very aware of it, and they are quite
picking
up all these things. They pick
The
up.
patient also finds that there is a tooth, because patient himself will say, this tooth I have a headache. So the tooth imaging they do for dental as this thing, it would invariably show some kind of infection. Then they say, why go to there, let us get rid of this. And when the pain persists or recurs, that is the time when the neurosurgeon comes into the picture.
Do these patients, do they develop stroke or something later because they don't get treated with trigeminal neuralgia, develop a brain tumor? So many people may be having fear like that. So I don't think there's nothing like that. There is nothing. This is just a pain. This will not lead to death.
Basically, the pain which is so severe,
Yeah.
as if somebody is stabbing you. There was a patient who would not have opened his mouth to brush or even gargle his mouth because the pain gets started with that. Or because of that they don't brush, they don't even eat it. Sometimes they don't open their mouth. So we have seen many type of patients. One thing, it should be correctly diagnosed. Clinical management with medication is the first line of treatment. If that doesn't work, then we should do an MRI to look for any cause which is there. One of the rare causes could be due to small tumor or something. That is, if that all things are ruled out, then we look for what is known as blood vessel. And if there is a blood vessel, surgical intervention gives a good result among all the methods that we have discussed. Risk of surgery is minimal, provided they don't have other risks related to lung or heart or whatever. Of course, those things will be checked by the anesthetist before we put you on the operation table.
So I think today we had a brief discussion about trigeminal neuralgia, and many people, their false beliefs, myths about trigeminal neuralgia have been washed out, and many people have come to know that a condition like this exists for which surgical treatment is there. So summing up, basically sharp shooting pain, the response to carbamazepine, MRI shows neurovascular conflict. If does not respond to carbamazepine, surgery can be done with very safely with very good results. So thank you.